You are listening to the global network of podcasters dedicated to the pharmacy profession. Welcome to the Pharmacy Podcast Network.
We have an aging population taking more medications than ever before. On this podcast, I will interview experts in geriatric medicine to gain insight so we can provide optimal care to patients in their golden years. I'm your host, Dr. Tamara Ruggles, and this is the Geriatric Pharmacy Focus. Hello and welcome to the Geriatric Pharmacy Focus. I'm your host, Dr. Tamara Ruggles, and with me is Dr. Lipid himself, Dr. Thomas Dayspring. We're so excited to have him back. Thank you for joining us. Dr. Dayspring is a fellow of the American College of Physicians and a fellow of the National Lipid Association. He practiced in New Jersey nearly 40 years and now is retired but staying very busy because he's the social media ambassador for both the European Atherosclerosis Society and the National Lipid Association, giving thousands of lectures, interviews on podcasts, and just staying very busy. If you're not following him, you need to be. Dr. Lipid on X and Dr. Thomas Dayspring on LinkedIn. So welcome, Dr. Dayspring.
Good to be with you again, Tamara. And I guess I qualify as a geriatric person. What your podcast is entitled, so perfect.
That's right. This is perfect. So we've had you on two different episodes. One was just kind of a generic lipid podcast, the Lipid Lowdown. The next one we dove into lipoprotein little a. And since meeting you and learning so much more about lipids, now I said, can you come back and talk about Desmosterol? Because I think it's something not a lot of people know about. But I do think it's important for pharmacists to know about Desmosterol because of medications and how they can affect Desmosterol and what that means for our patients. So thank you for coming to talk about this very complex topic. But if you can first teach us a little bit about exactly what Desmosterol is.
Yes, a little bit of biochemistry will be involved in today's talk, but Desmosterol, if you look at the last five letters, is a sterol. Sterol are a group of cyclic lipid molecules that are the basic structure of all of the steroid hormones and everything. But, of course, the sterol most everybody has heard about is cholesterol. So that is one of the sterol family has probably 100 different sterols in it. And even though very few people are cognizant of anything else other than cholesterol. So we're not going to discuss every sterol in this podcast, thank God. But to understand what you're interested in, Desmosterol, we have to basically understand the cholesterol synthetic pathways. And it's a very complex pathway. It's not A plus B equals C, C being cholesterol. There's over 30 steps in the synthesis of a single cholesterol molecule. It basically starts with either a 3-carbon molecule, acetate, acetic acid, or a 5-carbon molecule, citric acid or citrate, and that, of course, comes out of the Krebs cycle. Now, through many stepwise modifications, those 3 or 5-carbon molecules become longer. They're adding carbon-hydrogen atoms. Everybody, like the third step is the creation of mevalonic acid, and most people are a little bit familiar with that because the enzyme that causes that to be generated is HMG-CoA reductase. And of course, that's the enzyme that if we inhibit with statins, we slow down the cholesterol synthetic pathway. But mevalonic acid becomes longer, and it becomes the longest still linear molecule called scalene. That is 30 carbon molecules long. It's a gigantic molecule, and you really can't have things getting much longer than that. And what happens is it starts to turn on itself. It cyclicizes. It becomes a cyclical molecule. So the 30 carbon scalene turns into a 27 carbon sterol called lenosterol. And the sterol structure is basically 4 rings, 3 6-carbon rings and 1 5-carbon ring. And on the 5th carbon, happens to be carbon 17 if you count all the carbons, there's a tail that sticks up off of it. And that tail is pretty much what differentiates the different sterols. Cholesterol has an 8-carbon saturated tail, and that's cholesterol. Now, on the first ring at the third position, there's a hydroxy molecule on virtually all of the sterols. And that's what gives sterols their interesting physical a thing that makes it so functional in cell membranes. One side, the hydroxy side, is soluble in water, and the other side, with that 8-carbon tail, is lipophilic. It's hydrophobic. So that's what we call an amphipathic molecule. One side water soluble, one side lipid soluble. And that's why sterols are particularly well positioned to align themselves between phospholipids and cell membranes. The hydroxy group sticks out and interacts with the water in the plasma, and the lipid end interacts with the lipids in the cell membrane or the cell structure. In the same way on the structure of lipoproteins, sterols, that's a unilayer, not a bilayer, but it's sterols between phospholipids. So linosterol is the first sterol that's going to become cholesterol. And interesting, evolution has given it 2 pathways from which to become cholesterol. The first many steps where citrate acetate becomes squalene, that's it. There's one pathway. But then linosterol, and here's where linosterol can go. There's 2 separate pathways. And the one, which is the more common pathway and is used primarily by all the peripheral cells in the body, goes through several more steps, but what we call the penultimate, next to the last sterol, that through one further enzymatic action becomes cholesterol, is lithosterol, LATHO sterol. So, by the way, if we measured lithosterol in the bloodstream and it's high, we know that the cells that use that pathway are oversynthesizing cholesterol. That pathway, by the way, was discovered, and it now carries the name of the 2 discoverers, the Tan-Dutch-Russell pathway. So not that anybody's ever heard of that, but I like to give credit to the geniuses who discovered these pathways. But there's another pathway that linosterol can become cholesterol by, and it goes through several sterol intermediates, but the penultimate, the next to the last sterol that will become cholesterol, is what we're talking about today, desmosterol, DESMO sterol. And interesting, that pathway is pretty much used by the brain, and maybe in the adrenal cortical cells in the gonads. So in the periphery, desmosterol pathway, by the way, which is named the Bloch pathway after Conrad Bloch, who actually got the Nobel Prize for discovering this pathway, is kind of very important. So that's the Bloch pathway that goes through desmosterol. Likewise, if I measure desmosterol in the blood, I have a handle on synthesis of cholesterol, but pretty much in the brain, because in the periphery, it's lithosterol. Now, that testing is widely available. Lithosterol and desmosterol can be obtained at the Boston Heart Lab. LabCorp will do it if you request something called plasma sterols, but they ship it out to the Mayo Clinic for analysis. And of course, if you have a relationship with the Mayo Clinic, the lab, they also will check sterols for you. If there are others, I'm not aware of them, but there is a nice direct-to-consumer method of getting desmosterol and lithosterol levels, as well as the markers of absorption, which we're not talking about today. Those are the phytosterols. It's called Empowered DX. If people Google that, they'll go to their website. They send you a little mini test tube and a lancet. You prick your finger, put a couple of drops of blood in the thing, and ship it back to them. And they actually send that tube to the Boston Heart Lab for analysis. And that is probably the lab that's doing the most of these studies nowadays. And the developer of sterols, Ernie Schaefer, is the director of that lab, and they're quite excellent at doing sterol concentrations. So the real reason to measure desmosterol lithosterol is we're looking for hypersynthesizers of cholesterol, because if we see, hey, somebody's got a high LDL cholesterol or ApoB, and lithosterol and desmosterol are elevated, I know, wow, I have to inhibit synthesis if I'm going to reduce ApoB or LDL cholesterol. And of course, that's where the statins or bempedoic acid come into play, the two drugs that are available to us that inhibit cholesterol synthesis. So now that we understand this, we're going to punt up to the brain. Remember, the brain is separated from the plasma by that very tight blood-brain barrier. That means lipoproteins carrying cholesterol cannot cross the blood-brain barrier and deliver cholesterol to the brain. That's why when we aggressively lower LDL cholesterol in the plasma to reduce atherosclerotic events, we are influencing the brain to no degree. You can make the LDL cholesterol 15 with some of the PCSK9 inhibitors and statins, and it has no effect on brain function. They've done extensive studies checking that out. And that just tells you the cholesterol being maybe the most prominent molecule that is in the brain is totally synthesized by brain cells because it cannot get cholesterol anywhere else. So the brain cholesterol synthesis is a very interesting tale. It actually starts in utero in like the second and third trimester. Early on, it's mom's cholesterol that is supplying the fetus with their cholesterol needs. But in that second and third trimester, they're still getting mom's cholesterol, but they start making it themselves, the little fetus. Of course, the second you're born, you're not getting mom's cholesterol anymore. The brain has to synthesize all of the cholesterol. And the brain, from the day you're born, has a lot of growing still to do. In fact, it keeps growing until about the age of 10 or very early adolescence. So up until that age, from birth till, so let's say 10, every cell in the brain is producing cholesterol very aggressively. But there's only a few cells in the brain. We have the neurons, pretty important cells, and a bunch of other cells that are grouped together called glial cells. And the glial cells that produce the cholesterol are basically oligodendrocytes, because cholesterol, that's the cell that makes myelin, which coats every axon and dendrite in your body. So throughout life, oligodendrocytes make the most cholesterol in the brain, but they use it by themselves to make myelin. They don't share it with the other cells in the brain to speak of. So the other cells would be the neurons and astrocytes. Now, up until age 10, both neurons and astrocytes are making a lot of cholesterol. And because the neuron needs a lot. The neuron works because of its functional cell membranes. And what are the two components of cell membranes? Phospholipids and cholesterol. So the neuron absolutely has to have the proper amount of cholesterol. So up until age 10, it's making it. But around that age, the neuron says, I'm going to stop making cholesterol. And here's why. I've told you that over 30-step process of synthesizing cholesterol, it's incredibly energy requiring. To synthesize one molecule cholesterol, it requires over 30 molecules of ATP. And the neuron doesn't want to waste ATP on making cholesterol, because the neuron needs ATP to make all its synapses fire off the impulses that make our body function. So it would rather conserve ATP and do what neurons do, generate action potentials. So once the neuron says, I'm not making cholesterol anymore, it becomes the job of the astrocytes to make cholesterol and then ship it over to the neurons. And they do that not through the plasma. The neurons, all the glial cells, they exist in brain interstitial connective tissue that is called the matrosome. And they all lie very close to each other. All these cells are pretty much touching each other. So if an astrocyte synthesizes cholesterol, it wraps it in a brain lipoprotein, which has the buoyancy and density of a plasma HDL particle, except its protein is ApoE, not ApoA1, as is on the HDLs in the plasma. So the neuron makes an ApoE HDL particle, ships it into the matrosome, and it sort of floats over and goes to the neuron, and the neuron has receptors that can either internalize that particle, getting cholesterol, or it can delipidate it using a different receptor, again, getting the cholesterol it needs to function. So that's pretty much brain cholesterol synthesis. By the way, the half-life of cholesterol molecule in the brain is 5 years. The half-life in plasma is about 3 days. So this shows you the brain really conserves and reutilizes all of its cholesterol and then keeps synthesizing whatever it has to. But here's where the story comes back to desmosterol. The astrocyte, which in adults is producing most of the cholesterol that neurons are going to use, uses the block pathway through desmosterol. It does not use the Can-Dutch-Russell pathway through lithosterol. So researchers who started to understand this, I think around 2012 comes the best study that's going to support what I'm about to espouse as a theory, is that if the desmosterol is the marker we can measure for brain synthesis. Can we prove that? And here's what they did. They had a bunch of patients, like 100 of them, and they did spinal taps on everybody. And of course, they drew blood in the plasma through the antecubital vein. And they checked desmosterol in the spinal fluid, and they checked desmosterol in the peripheral your lipoproteins that are floating around. And they have a high correlation. And that established the fact that we can actually measure desmosterol in the plasma, and it tells us what's going on in the cerebral spinal fluid, which certainly tells us what is going on in the brain, because the brain and cerebral spinal fluid exchange things all day long. So these researchers then went on and looked further, and they said, oh my God, look what we've discovered. People who have low desmosterol, both in the cerebral spinal fluid, but equally so in the plasma, are prone to cognitive impairment and Alzheimer's disease. So bingo, they discovered a plasma biomarker that we can use to estimate somebody's risk for developing cognitive impairment or Alzheimer's disease. And that's important to know because there are many therapies you can introduce early in life, many of them lifestyle, some particular supplements that will probably lessen the onset or delay the onset of Alzheimer's disease for those who are so prone to get it. We often check ApoE4 genotype as a good way to see who's going to get Alzheimer's disease, but we can now add desmosterol to that list as a plasma biomarker. And if you ever have a patient who had a family history of dementia, or they tell you I'm not thinking right anymore, or people have noticed that of them, or for sure if they carry an ApoE4 allele, you might want to check desmosterol as one of the tests to help you say, wow, I think there's something going on here, and get them to people who are preventive neurologists and know what to do on this. So there's the other side of the story, though, too. Alzheimer's disease is related to too much cholesterol in the brain. When that neuron membrane starts to acquire extra cholesterol, that's when a lot of things go on interplay and they start producing amyloid beta and tau, which are two great biomarkers to tell us somebody's going to get Alzheimer's disease. And they are actually involved with the development of Alzheimer's disease. So this would at least raise to the theory that, why, my God, if I'm worried about somebody getting Alzheimer's disease or strong family history, ApoE4 alleles, blah, 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 maybe I want to lower brain cholesterol a little bit so the neuron does not get cholesterol toxicity. Now, how can we lower cholesterol synthesis in the brain? Well, we do have a lot of cholesterol-lowering drugs that we use to lower cholesterol in the plasma, but of all of them, only one can cross the blood-brain barrier, and that is statins. And forget the lipophilic, hydrophilic stuff. Yes, a lipophilic might get in a little easier than hydrophilic, but if you're on a statin that's in steady state, they all get in. I mean, if you take one statin today, rosuvastatin, hydrophilic, and another tomorrow, simvastatin, the simvastatin will get in quicker if you look at those type of pharmacokinetics. But if we're looking at steady state, you're on a statin, you, to a certain degree, are going to inhibit cholesterol synthesis in the brain. And since Alzheimer's is becoming an epidemic and so many people are getting it, and other types of dementia and cognitive impairment, It actually makes perhaps a little sense to somewhat lower cholesterol synthesis in the brain. We have numerous statin trials done over time, got 30 of them, and some of them have actually looked never as a primary outcome, but secondary outcomes. Do statins help cognition? And if you do a meta-analysis of those studies that actually looked at least some feature of cognitive impairment, the conclusion is statins are null on Alzheimer's disease. They don't hurt anybody or cause Alzheimer's disease. So anybody spouting that on the internet, reject them because there's no evidence that that is true. But there actually were a few studies that suggested statins do improve the development or lessen the development of Alzheimer's disease and cognitive impairment, which would make sense if, hey, we do lower cholesterol synthesis a little bit, and somebody who Alzheimer's disease of too much cholesterol in the cell membrane, that at least makes sense. It's a good theory right now. But then I raised the theory that that's great, but what if somehow we over suppress the synthesis of cholesterol in the brain, with the caveat that the brain only can get cholesterol through synthesis. So I think it's certainly plausible that we do not want to suppress cholesterol synthesis in the brain. And this is where monitoring desmosterol might come into play. Now, this is totally a theoretical supposition now. Nobody's done a trial to say, geez, what Tom is saying now is absolutely true. But we certainly know low desmosterol in the CSF or the plasma is a biomarker of Alzheimer's disease. We know too much cholesterol causes or degenerates the things that cause Alzheimer's disease. At least some of the statin data suggests lowering it a bit is going to help some people. But what about lowering desmosterol too much? Then I go back to that study that says low desmosterol is causing cognitive impairment in Alzheimer's disease, or is at least associated with it. So I come up with the theory, maybe we do not want to oversuppress cholesterol synthesis in the brain. And the number one drug, of course, that can do that is statin therapy. Now, listen, this is why I believe it's good to check desmosterol before you start statin therapy. Because say you came to me and I know, oh my God, you got a high ApoB or something, we got to get you on a statin. But I want to check your both ApoE and your desmosterol level at baseline. And if at baseline, while you're not on a statin, your desmosterol is low, especially if you're an ApoE4 carrier, I know you're heading down the wrong road. And if I have to lower ApoB in that patient, maybe I'm going to choose one of the other drugs, none of which do anything to cholesterol synthesis in the brain, ezetimibe, bempedoic acid, PCSK9 inhibitors, some other drugs that are soon to come. So this is a nice theory there that goes on to it. Now, what if you're already on a statin, as millions of people are, and they should be because you have to lower ApoB. So it's the most widely used, at least initial drug. Combination therapy is becoming more common, but the vast majority of clinicians do start with statin therapy. And fine, I got no problems with that. And you're going to see if it works. In a couple of months, you're going to repeat the ApoB, LDL cholesterol, non-HDL cholesterol, and see is the statin working. But I would suggest at the same time, you might want to repeat the desmosterol level, even if you do not have a baseline desmosterol. And if on the statin, the desmosterol has dropped below the 20th percentile, and that would be 0.8 milligrams per liter if you use these labs that I spoke about, perhaps you have oversuppressed cholesterol synthesis in the brain. And with the information we at least know, the study linking it to AD is pretty solid. But my theory is if you're lowering desmosterol, a marker of brain cholesterol synthesis with a statin, you are likely oversuppressing cholesterol synthesis in the brain. And that's probably not good. Just a theory at the present time. But no other theories. And with the information that low desmosterol is not a good marker to have, I think it's wise that if on a follow-up you see you've suppressed desmosterol too much, to perhaps use some of the other ApoB-lowering therapies. Now, if you jumped in with a high-potency statin, as many people are nowadays, which the guidelines suggest, and you really suppress desmosterol, maybe you could start reducing the dose of the statin, and on a subsequent blood test, see have you still oversuppressed desmosterol. If you have, keep reducing the dose. And now you might say, but wait a minute, LDL cholesterol or ApoB is going to go up. So what? Then you add ezetimibe or bempedoic acid, or if it's a really nightmare, a PCSK9 to the regimen. And you can get ApoB under control with having no influence on brain cholesterol synthesis. So this is pretty much the whole theory that I put together going on with this, with the low desmosterol. But I want to end this little speech of mine. What about is it possible to increase desmosterol in the certainly the cerebral spinal fluid, the brain, or in the plasma where we're measuring it? And the answer is yes. So to show you why low desmosterol is no good, I just explained that, but should we also be worried if for some reason a person has high desmosterol? And yes, we should. And here's the data. And nobody knows this except geeks like me who've gone back and studied everything ever done to cholesterol. So most people don't know what is the first drug that got FDA approval to be used by clinicians to lower cholesterol. 1959. Even I was like starting high school then, so I was not aware of this study then, but I've since gone back and visited when I wound up as a lipidologist. So Merck developed a generic drug called triparanol, Triparanol. And the brand name, it was actually like, I believe, the 29th drug they ever invented, so they called it MER for Merck, MER 29. And the FDA let it come on the market because Merck showed, hey, it lowers cholesterol. And they pretty much were just measuring LDL cholesterol in those days. There was no LDL cholesterol biomarker available then. So they showed it lowered total cholesterol. And the FDA said, okay, and they, I don't even think the FDA asked for any adversity studies like they would for today. And back in 59, you didn't need to come with an outcome trial showing your drug works. All you had to do was show it improved a bad biomarker, total cholesterol. All right. And then all of a sudden, about 2 to 3 years later, Merck, because they knew the FDA was going to yank it, pulled it from the market because they were starting to see adversity. And the adversity, number one, was the development of cataracts. And number two was actually increased coronary artery disease and some other morbidities also. So how in the world did that happen? Well, how did the drug triparanol lower cholesterol? So remember, desmosterol becomes cholesterol. There's one enzyme that converts it. It's called DHCR24, dehydrocholesterol reductase, and it reduces the double bond at the 24th carbon. That's where the 24th, and that's in that 8-member tail. So now, if you are preventing desmosterol from becoming cholesterol, you're going to reduce cholesterol in the blood. Yay! But wait a minute, what might you be increasing dramatically in the blood? Desmosterol. Because it's got nowhere to go. It becomes a predominant sterol in these people. And it's all of a sudden not cholesterol going into the cell membranes, it's desmosterol. And desmosterol causes dysfunctional membrane activity. Your membranes want cholesterol. That's what they're designed through evolution to work with. They don't want other sterols in there. And that's why desmosterol turned out to be bad news. And I guess the first tissues it impaired is cataract, the eye. So cataracts, the epithelium over the lens started to get screwed up. So we've known since then, and it got yanked. And because that was 1959, 1962, nobody ever has taught about triparanol anymore. Nobody has ever heard of it, except researchers like myself who've gone back trying to understand cholesterol and all of the drugs that putz with cholesterol, and you stumble across that if you go back and start to review it. So it's amazing. That's basically been hidden from modern cholesterol teaching, and it shouldn't be. So now all we have to worry about is, God, is there anything today that can raise desmosterol in the blood because it's inhibiting DHCR24? It's causing it. By the way, if you have genetic total loss of function of DHCR24, those little babies either die in utero because they can make very little cholesterol in their brain. And if they don't die in utero, they are born with severe neurologic impairment and they die pretty early in life. That disease is called desmosterolosis. Now, they have massive increases in desmosterol because they can't change any desmosterol to cholesterol. The drugs that we now are aware of that can increase desmosterol, they only partially inhibit that enzyme. So they don't totally shut down cholesterol production, and they don't send desmosterol through the roof, but they send it pretty high enough that once we know desmosterol can cause cataracts and perhaps other morbidities, if you're going to take a drug that does that, you better take it transiently and not chronically, so you're walking around with high desmosterol. And the most common drug that does that is a drug that's used for a lot of things, sometimes transiently, but unfortunately sometimes long-term, and it's clomiphene. Of course, clomiphene is used in reproductive endocrinology to help fertility and everything, but that's a transient use. I don't think you're going to give any mom trying to get pregnant cataracts because you're raising clomiphene for a few months or whatever you're doing it for. But what is clomiphene also used for, especially in men who have gonadal insufficiency, low testosterone? They're prescribed various types of testosterone, but they're often given clomiphene, which enhances the testosterone level, and they stay on it chronically. So believe it or not, the drugs that manufacture clomiphene nowadays have been advised to the FDA wants a reporting on they have to follow up with cataract development in their patients. So if anybody is using clomiphene chronically, and pharmacists are the best to know that because they're filling their scripts all the time, they might at least want to do some research on elevated desmosterol caused by clomiphene. And cataracts is going to be the first possibility. I would contend that if they did it long enough, they're going to get other morbidities related to cell membranes, red blood cell membranes, possibly anemias. So that's the desmosterol story in a nutshell. You can whip questions at me to try and unconfuse what I've said.
Oh, I think you did a great job explaining. I think the cholesterol in the brain is so fascinating to me, and the fact that we can now, measure desmosterol in the periphery and it'll correlate to desmosterol levels in the brain. What a gift for us to be able to have that and use that in our practice. And so I just wanted to say this because when I first got my desmosterol levels from the Boston Heart Lab, they can kind of report it goofy, but what you want to look at is the absolute value. And so that's what you've taught me. Look at the absolute value when you look at the report of desmosterol levels. And too low would be anything less than 0.8 milligrams per liter. And right now we would define too high as greater than 1.5 milligram per deciliter, looking at the trials and the data that we currently have.
Let me just mention that was a great point for people who are going to get the Boston Heart Lab, either because they use that or they go through that Empower DX and get the Boston Heart Lab. Boston Heart Lab reports sterol concentrations via two methodologies. Well, the methodology is the same. It's liquid chromatography, mass spectrometry, but they report the results as a ratio of the sterol level, in this case desmosterol, to total cholesterol, and they call that the normalized value. But also, and you got to look at the right side of the report form, you will see a column that says absolute concentrations, and that's where you'll see the concentrations you just elaborated. Here's the problem with the ratio. That's basically a tool for epidemiologists who want to compare groups of people. And this way you're adjusting for something that both groups might have. But imagine if you're on a lipid-lowering drugs. You're going to lower total cholesterol significantly. And that screws up that total rate, but the lipid drugs aren't doing much to the desmosterol itself. So the ratio becomes goofy. And you'll see nice color bars in the report, which are color bars representing the normalized ratio. So I always advise people to ignore the color bars, ignore the ratio, and skip over to look to the absolute concentration. Now, the bad news is Boston does not tell you an absolute concentration. Is it at the 20th, 30th, 40th, 80th percentile? You have to have that data. I've tweeted it out and put it on LinkedIn many times. You have it. Maybe you could share it. Maybe I'll post it again today on X so people who are listening to this podcast can print it out. It's just a nice color table, and you will see all the values of the desmosterol and the lithosterol. The lithosterol you use for evaluating peripheral cholesterol synthesis. And that can actually tell you how is the statin working, because you should see a nice suppression of lithosterol. And there's no worries suppressing cholesterol synthesis in the peripheral cells, because even if you did reduce plasma cholesterol, every cell in the body can make all the cholesterol it needs. So you're not screwing up any cells by lowering lithosterol too much or altering peripheral cholesterol synthesis. But we have a big study that lowering desmosterol in the brain or having low desmosterol in the brain is a biomarker of AD and cognitive impairment. So you got to understand how to interpret every blood test you get back. Your podcast goes out to pharmacists too, so I want to warn them. You guys and gals can be looking at this, but understand, I would say 99% of physicians in America are unaware of cholesterol synthesis and the biomarkers of cholesterol synthesis. And if you tell a patient, maybe your doc should measure desmosterol, then you might get an angry call from the doc. Stop telling my patients things that I don't know about. And then that's why it's good to have some of the references around that you can share.
Yeah, that happened to me with my own dad, because he was started on a statin for his high CAC score. And him and I both have high lipoprotein(a). And I asked his cardiologist if he would measure desmosterol, and they weren't happy with me. They called me the helicopter daughter. But I'm going to get his checked anyway, because I don't want him to get, cognitive decline from being on a statin. And he needs to be on, lipid lowering medication because of his high CAC and his lipoprotein(a). But I would like to keep his desmosterol between.
What is the harm of checking this and then being at least aware of the data? And then you can make your own decision. But at least knowing we don't necessarily need statins to lower cholesterol. We have several good other drugs. And even if you had to make the case for a more potent one with a third-party payer, basically that's a statin intolerance if you're lowering desmosterol, which might qualify you for other type drugs.
Oh, yeah, that's a great point with the prior auth paperwork. So, yes, and I wanted to say, too, I started rosuvastatin about 3 months ago. My desmosterol levels went from the 50th percentile to the 40th percentile, but we're still above 0.8, so I'm happy with that. I'm happy that you've trained my physician to monitor such things.
Yeah, and I would say, regardless of what your risk for Alzheimer's disease is, lowering your cholesterol in the brain a little bit is probably good, because too much cholesterol in the neurons is a precursor of you're going to get neuronal injury as time goes on.
Right. So we talked about statins and how they can lower desmosterol. We've talked a little bit about clomiphene and how they can increase desmosterol. What are some other commonly prescribed medications that can either lower or increase desmosterol levels?
The one that can be involved with desmosterol is trazodone. It's used for depression or for sleep. That can also screw up desmosterol and even lithosterol, because they've checked that in the brain on some people, the people who did the study with that drug. So that's another one you want to keep an eye on it or so and see what's happening to desmosterol. And in there, checking lithosterol in the peripheral, because trazodone in the study was reported, and I think it was autopsy studies where they could measure trazodone in the brain tissue. Checking lithosterol in the periphery tells you nothing about the brain, because 95% of it is coming from peripheral cells, whereas desmosterol, most of it is coming from the brain cells. So that's why lithosterol doesn't become that useful, other than, hey, the statin is working because it's lowering lithosterol in the liver and where I want it to, but it's the desmosterol that tells us about what's going on in the brain. So that's the other drug that is more commonly used. And, it's used for a lot of reasons, sleep and depression.
Mm-hmm. Two of the medication classes I was surprised to see on that. You sent over a nice report, which I will attach to the show notes. But they mentioned antipsychotic medications such as aripiprazole, haloperidol, and then they also mentioned some commonly prescribed beta blockers such as metoprolol. So how do those affect desmosterol levels?
I have no idea, but since they've done the studies and they've checked the levels in a lot of people on a lot of drugs, I would suggest if you got a low desmosterol level back, remember I told you, please, if possible, check it before you start a statin, and it's low there, you know they're at risk for AD, but then you want to pull that article and start, aha, you're on this drug, so maybe we have to play with that drug if possible or so. So I think it's a very useful reference to keep around because the list is long. It's easy for me to tell you how the lipid modulating drugs do it, but how these other drugs do it, whether it's through adrenergic effects with a beta blocker that's somehow affecting production of it in the brain, I don't know. You know, there's another biomarker which unfortunately we can't get. Evolution knew too much cholesterol in the neurons is bad news. So the evolution actually gave the neurons an enzyme that no other glial cell, including astrocytes, have, and it converts cholesterol to an oxysterol called 24S-hydroxycholesterol. That means it not only has a cholesterol at the third carbon, as all sterols do, it has a hydroxy molecule on the 24th carbon. And that's these oxysterols are actually basically they're bile acid precursors. The liver changes cholesterol into oxysterols, and they go through several other steps and become a bile acid, which then becomes a bile salt. So the brain is actually creating like early bile salts. And because it has a hydroxy group on each end of the molecule, it's actually a hydrophilic lipid molecule. Very unusual. So when the neuron changes cholesterol to 24S-hydroxycholesterol, it can pass through the neuron cell membrane into the matrosome, and it can pass right through the blood-brain barrier where it jumps on an albumin that's cruising by or a lipoprotein that's cruising by, and they bring that oxysterol to the liver, which says, hey, thank you for supplying me with some bile acid precursors. And it changes them into bile acids and they get excreted in the bile and fecally if the body so desires that. So I kind of laugh, hey, nobody knew the brain cells are connected to the small intestine, but they are. And the neuron is the only cell that contains the enzyme that converts cholesterol to 24S-hydroxycholesterol. Now, in research studies, people doing neurologic studies always measure 24S-hydroxycholesterol because if it's in your plasma, and that's where they're measuring it, of course, the only source is the brain. Other cells don't make 24S-hydroxycholesterol. So it's a good marker, and if it's high in the blood, it tells you the brain has too much darn cholesterol, and the neuron is trying to get rid of it. So that's another biomarker that is used as it's a precursor of Alzheimer's disease too, because it's an indication the neuron has too much cholesterol. Now, interesting, statins, which slow the synthesis of cholesterol in the brain, therefore the astrocytes will make less cholesterol, ship less cholesterol to the neurons will stop making 24S-hydroxycholesterol. So a good biomarker, if you tested 24S-hydroxycholesterol in the plasma and it's high, you worry, but if all of a sudden it goes down, you say, I'm probably helping that patient. But then I would tell you, go back and make sure you didn't lower desmosterol because you've 24S-hydroxycholesterol will be low, but that's because you've over-suppressed cholesterol synthesis. So I wish we could actually get both of those biomarkers because then we would have even a more thorough analysis of cholesterol homeostasis in the brain. Right now, it's a research tool. And maybe one day it'll become available, but I don't know. It would take a lot of studies. Labs don't want to do it because they can't get reimbursed for doing it. So that's your problem.
Sure. So yes, as far as desmosterol goes, one thing I did want to point out is the lowering or probably increasing is dose dependent. So it doesn't mean if you're on a statin and your desmosterol goes too low, it doesn't mean you have to stop it. You can lower it and then recheck desmosterol levels and see where they're at. And then if they are still low and you're on the lowest dose, yeah, maybe it's time to stop the statin and go to a PSK9 inhibitor or something else. But it is dose dependent. So I think that's one thing for pharmacists to keep in mind, like most side effects are dose
Sure.
dependent. And then one other thing I have two more questions. One is, have you noticed a difference in desmosterol lowering? I know we talked a little bit about hydrophilic, lipophilic statins, but does say atorvastatin lower that desmosterol a little more than rosuvastatin, or haven't you seen that in practice?
There's no studies on it that I know of. So in practice, it would be anecdotal data. So, and I've never kept track of people who are on the various drugs with respect to, maybe I should have in retrospect, but it would still be anecdotal data of lipid profiles on patients I've been involved with. Lots of docs are always sending me, hey, here's what went on with my patients. And those who follow me are starting to check that a lot. But no, so I can't answer that question. I believe once they're in steady state, they're all going to suppress cholesterol synthesis in the brain. Yes, if I had two people and I'm doing a single dose pharmacokinetic study, the Resuva might get in quicker, and you might start suppress cholesterol synthesis sooner than the atorvastatin does. But once you're on it for a couple of weeks, I think you're suppressing cholesterol synthesis in the brain. So I don't. Again, there's all of the statin studies that have looked at where they're either null on cognition or they lowered it. You might have to go back and look at which statin was used in that study, but all you're going to see is that statin improved dementia. Remember, and you know this, and I think pharmacists know it, a lot of people who start statins come back and might first complain to the pharmacist before they complain to the doc. Since I started this statin, I'm not thinking right. I can't add as well as I used to. I'm confused. That's called brain fog. It's actually listed as a minor side effect in the package inserts. And my total theory is those are the people that are super sensitive to statins, or maybe they got way too big a dose of the statin, and you really oversuppress cholesterol synthesis right away in those people. Now, most people don't get the brain fog when they start a statin, but my worry would be, okay, they're feeling great on their statin, but if for years upon years their desmosterol, their cholesterol synthesis in the brain is low, what is the long-term ramifications of that? Again, I'm theorizing things. And that's why even if a patient says, oh, I'm asymptomatic, my brain is working well, I'm taking this statin, that, the big dose, whatever dose, I would like to also follow desmosterol. Why do we follow lipids? Coronary disease is an asymptomatic disease. We don't wait and say, get the heart attack, and then we'll decide whether the statin we were using was good or not. We follow biomarkers to judge the statin efficacy. Well, now we have a plausible biomarker to perhaps follow on brain health in our patients. And with the epidemic of Alzheimer's disease, why not? Mm-hmm. All it takes is, yeah, you're going to confuse a lot of people, but they don't have to read 22 articles on this. There's a handful of articles and just one big study, at least telling us low desmosterol is bad. So I think it'd be a great research study for somebody to do, even in a small cohort of people on various statins or on statins at different doses. I'll bet all the statin trials, the blood still exists. They could go back and measure desmosterol in their bloods and see what their Nobody's going to do that probably, but look, those are they're generic. That data is available now. I think it'd be a great research project for somebody to go and do.
I agree. I would love to read it. So, okay, so as far as lifestyle modifications, and desmosterol levels. What do we know about? Do we know anything about that? If you get a baseline desmosterol and it's low, is there lifestyle modifications that can increase it, or is this all just dependent on your brain's, production of cholesterol? And this is without any medications. I'm talking if your desmosterol is low.
No, and certainly in the periphery, there are diets, especially getting rid of saturated fat, where obviously we know we can lower LDL cholesterol, ApoB. And in those studies, there's a few reasons why they do that, but saturated fat can cause hypersynthesis of cholesterol. So since it's the peripheral cells that are doing most of that, you can follow lithosterol if you want to see why is saturated fat screwing up my LDL cholesterol, and check lithosterol. But I don't, since the plasma cholesterol levels have nothing reflecting on the brain, there's no diet I know that specifically is engineered to lower desmosterol. I would tell you, as we do with all people, go on a very heart healthy diet, and you're probably helping your brain in a lot of ways, aside from even cholesterol homeostasis. But no, can't have an answer for you on lowering brain cholesterol. Yeah,
Yeah. Well, you're so sharp, Dr. Dayspring. What do you do to protect your brain? I'm curious.
I can't remember what I had for breakfast this morning, so don't judge my brain. So, no, listen, couple of things. Number one, being a totally statin and ezetimibe intolerant person, serious side effects with those drugs with respect to the muscles. I require a PCSK9 inhibitor and it's got my ApoB in the high 40s, low 50s consistently, luckily with just monotherapy. So I have a good response to that. But I've also, since I met my buddy, Dr. Atiyah, many years ago, and he put me on initially it was a hypocaloric diet with intermittent fasting, and it was low fat. I blew away all my abnormal biomarkers. And since then, where I did that for 4 years, but that's a tough diet to stay on forever. I started to gain weight again, and now I use the semaglutide, where I've lost an equal amount of weight, and I have all my other biomarkers that you can measure in excellent control. So I got to presume that's helping the brain also. There's certainly been analysis of some of the GLP-1 receptor studies where does seem to be lower dementia in these people. And I think sooner or later that's going to be proven as an endpoint, just like almost every day you pick up an article and they find out some other thing that GLP-1 is doing beneficially. Most recent would be fatty liver, which is hardly a stretch. We can believe that. We know it reduces MACE and certainly helps the insulin sensitivity and the diabetic control. So I am on a high-dose Ozempic, and I'm on PCSK9 inhibitors. I take low-dose colchicine, which is approved to stabilize stable chronic coronary artery disease. So I went on that. I don't know that likely lowers some inflammatory markers, but I don't know what that, if anything, does brain. I don't even know if colchicine can cross the blood-brain barrier. But that's what I do. I take, because I am under care of an excellent preventive neurologist, I take a couple of supplements which are involved with brain health. I make sure my omega-3 index is quite good. They're big believers that DHA is crucial for brain functioning, so I make sure my DH levels are good. And I take some of the B vitamins, which they use early in the cases because there's some other evidence that might help brain function. So I'm doing what I can with some expert neurologic advice, Kellyanne Neotis, Richard Isaacson, as to how to keep my brain going. And I do think I'm certainly more cognitive impaired at age 80 than I would with the recent memory. I see all these movie stars. I can't remember their names anymore. Remembering old-time Yankee baseball players. I used to be so fluent. I have to think hard to remember. So Kellyanne has done pretty extensive testing on me and has come to the conclusion with all the crazy tests that she did that I'm not showing the impairment of some of the neurologic cognitive things that would indicate AD. She says, Tom, you just got a 79-year-old brain.
Yep.
So that explains some of the recent memory issues that you're having and stuff. But, dementia, you have to be the activities of daily living. You don't know how to button your shirt. You don't know how to cook anything, turn on the tap, put on your clothes. I'm still functioning pretty good with all. And Kellyanne says, Tom, you doing the type of lectures and podcasts you're doing, you don't have Alzheimer's disease.
Well, you're absolutely amazing. I love learning from you. I will say, too, my omega index is checked. And when I first had mine checked, I was critical low with the DHA. And so, yeah, that was surprising to me. So I take quite a bit of fish oil every day, and now it's normal. So I'm thankful we had that checked. There's still a lot we don't know about cognitive decline, but there's a lot we do know quite a bit now. You could look at desmosterol, omega indexes, ApoE if you're an E4 carrier. So
And there are several other things they're measuring now. Some of the tau and amyloid. There are numerous biomarkers that preventive neurologists understand and use. And really, everyday docs could use them too, but it requires a little study. If you're going to order this test, you better know what it's going to mean when it comes back. But there's great podcasts. There's obviously articles you can be referred to learn about that. Most recently with an up-and-coming lipid-modulating drug, which I've likely spoken about with you before, called obicetrapib. It's the next CETP inhibitor that so far dramatically lowers ApoB, LDL cholesterol, non-HDL cholesterol, even more so if you combine it with a statin or ezetimibe. But it also lowers LP(a) by upwards of 40 to 60%. Wow, and it's a little oral tablet at 10 milligrams a day. Would that be beneficial for patients like that? It seems that people who take it, unlike the statins, there's a lesser incidence of the onset of diabetes, so it may be protecting islet cells there. But their biggest hope is, and they just presented this at the recent Alzheimer's disease conference, and it's in publication now, that it significantly improves some of the tau markers and beta amyloid in the blood. Now, wow, now that's a big step. Say, hey, we make them better and we're going to prevent Alzheimer's disease. That will require a lot further study. But that's tremendous biomarker data to see on this incredible little drug that's coming along. It's like the little engine that could.
Yeah, I love that it lowers lipoprotein(a) because, statins can increase it a little bit. So this sounds amazing. What phase trial is it in?
It's in phase 3 outcome trial now, a big one called Prevail, but it's not supposed to print out till late 26, early 27. They actually just published their Broadway trial, which is a trial of FH people and very high-risk people that if you add obicetrapib to high-potency statin or maximally tolerated statin, you can more suppress ApoB, LDL cholesterol than this high-dose statin could by itself. That alone could actually, I believe, get them an indication to come on the market as an adjunctive statin therapy. But I believe the New Amsterdam Pharma is going to wait till the Prevail style concludes, showing does it reduce MACE or not, before they apply to get an indication. But I also understand it's coming on the market in Europe pretty quickly. Things get on the market, I guess, more easily or whatever over there. So Europeans will be able to use obicetrapib long before we do. Maybe if you have an uncle who lives in England or someplace, they could ship it.
Yeah, right. I love some of the things that Europe does as far as their guidelines. And yeah, it seems like as far as lipids go, their guidelines are a little bit more up to date.
Yeah, they really are.
Yeah. Well, it's been such a pleasure having you on, Dr. Dayspring. I always learn so much. Thank you for all you do for educating all of us. And pharmacists, educate your patients. We can check desmosterol levels. We can know if they're getting too low or if they're too high. Good counseling, and get your own levels checked if you want to at Empower Lab.
Yep, and remember, it's pretty solid that it is a biomarker for AD and cognitive impairment. All of the stuff about lowering and increasing it is plausible theory at this time, but the data is pretty good. So make of it what you will. You can totally ignore it. But I think if I was able to tolerate a statin, I would do what you're doing, Tamara. I would keep an eye periodically on my desmosterol.
Absolutely. All right. Thanks so much, everyone. Have a great day.